we're going to talk about sleep. Key questions to ask when you get a new patient, and you should ask pretty much everybody how they're sleeping. Is it hard to fall asleep? Stay asleep? Do you wake up often? If you wake up, do you fall back asleep okay? Do you toss and turn a lot? Or do you get kind of restless? Or do you find yourself hurting yourself every night when you wake up because you've been in all sorts of places? If they've got CPAP machines or something, is it getting wrapped around their neck? Stuff like that. And then also how their cycle is, right? Depending on work schedules and stuff, some people won't have a normal circadian rhythm, but just finding out if they're going to bed at a reasonable time and waking up at the right time, or if they're getting tired at the right time. Those are questions to ask, and now we're gonna kind of go through what you would do about it. So first thing is gonna happen, this is the eye. So you got the eye is gonna see light, right? So that's gonna transmit its information back to the thalamus. And in the thalamus, all the visual information goes through the lateral geniculate nucleus. Now, we're not gonna go over vision so much as we are just light's role on sleep. And so there's a particular piece called the intergeniculate leaflet. So that's what we're gonna focus on for the moment. So we're gonna call that here, that guy. And then it's going to receive information from the pineal gland as well. And it's going to communicate with the hypothalamus. So you've got geniculopineal tract, which we currently have, and that's going to go between, we're just going to put the pineal gland up here, okay? This is not necessarily anatomically correct, but it's a little too crowded for me to draw it all. Anyway, so geniculopineal tract is going to go from there to there and communicating the circadian rhythm, and then it's going to go from the geniculohypothalamic tract. And this part we don't have yet, but it's going to go between the intergeniculate leaflet and the suprachiasmatic nucleus of the hypothalamus. Okay, so that's going to be the main determiner of circadian rhythm, but not the only one. It's also important to remember, a lot of these are going to have very specific roles and functions in research and whatnot, and you'll see like that's perfect for this particular condition, right? But it does not always mean that that dysfunction comes from there, even though most of the time it will, so don't necessarily ignore it, but focus there. If it doesn't work perfectly, that's okay. There's still probably something else involved in that, and you just kind of need to keep your mind open for some of the other possibilities, and some of those are coming up now. So within the hypothalamus, we have multiple nuclei that are going to have roles in sleep. So like I said, the suprachiasmatic nucleus is one, the arcuate nucleus is another one, and that's going to be particularly important for REM sleep later. Arcuate hypothalamus is one. And you kind of have the contrary stuff. So some are going to promote sleep and some are going to cause wakefulness, right? So the wakefulness can cause problems with sleep as well. So focus on the sleep here first. So you got the arcuate, you got parafornical. That one ties in with like rage and anger and stuff with the locus coeruleus, which is also a wakefulness thing. So that can kind of go either way. You've got the mammillary and tuberal nuclei, which are going to help with REM sleep or paradoxical sleep, kind of like a narcolepsy situation, as well as some of the memory things. And the tuberomammillary nucleus and the lateral nucleus are the primary makers of orexin, which is the wakefulness side of things. So that's where that can get kind of mixed up. And then some of the things that are going to control falling asleep is going to be the ventrolateral preoptic nucleus and the dorsal medial hypothalamus. So dorsal medial is also going to be a big part of the circadian rhythm, and if that's not working, you won't have one. And it also controls a lot of appetite and drinking behavior and stuff like that. So if you find some connections between those two, these two guys are there. They don't directly communicate with each other very much, but they have very similar roles. So if you can't fall asleep or fall back asleep, these two guys are there. VLPO is helping you like maintain sleep, but not necessarily get completely into REM sleep. And this is where your Ambiens and clonazepams and stuff tend to work. So it'll initiate sleep, but they don't get good sleep because that's the only part that it's hitting. So from there, so these are important because they're melanin concentrating hormone neurons, which are going to come down to this subceruleus stuff. Oh, and this doesn't necessarily cover nightmares either. That's a whole nother thing. Probably do that more with the PTSD type stuff. But this is just sleep. Now, some of these things can affect nightmares and they can affect that stuff, but not primarily. So next up is you'll get a little input from the hypothalamus, right up here, and a little bit from the amygdala right there. You can totally read that, right? Okay, so then you've got this tract, so we're going more to REM sleep in particular. So the amygdala is going to come down here to the subceruleus, which is right there, right underneath the locus ceruleus. We'll just make it a little bigger. So little one's the sub-C. Now this is the most important nucleus for REM sleep as far as having the muscle paralysis, so that you're not kicking and moving and sleepwalking and all sorts of stuff. So what I'm about to go into is the disorders you would see with it. It's called the REM sleep behavior disorder, where people like fight in their sleep and they don't ever wake up. So they really hurt themselves, or they can hurt other people because they're so active while they're sleeping. And also narcolepsy and cataplexy. So when people are falling asleep or having unwanted muscle paralysis in the middle of the day, they just kind of hit the deck, and they also can't sleep at night. These are big problems. So this is the center of it all. But it does have a little bit of play up into the hypothalamus as well, like those tuberal nuclei and lateral hypothalamus as well. But this is where the brunt of it is. So those are the key disorders, but it doesn't mean that those are the only people that benefit from it, because there's a lot of people sort of on the spectrum of these problems that aren't full-blown pathologies, right? So some people still tend to fall asleep in the middle of the day when they don't want to, and other people can't get into a deep sleep, or they toss and turn all night long and they never get restful sleep. This still totally applies to them, right? So it can be quite a useful tool. We've already seen it, we haven't had it for that long. Okay, so sub-C is then, their subceruleus is going to transmit its information. Once it gets it from the central nucleus of the amygdala, it's going to send some info down to the ventral medial medulla, and that will directly inhibit the motor neurons. So this, we just called the subceruleomedullary tract, and this the amygdalo ceruleus tract. So those are just the names of those two guys. Pretty quick and easy treat. Now, the sub-C isn't the only thing that initiates REM sleep. You've got a couple things that I guess help transition into it. So you've got the ventral lateral periaqueductal gray, and then you have the pedunculopontine tegmental nucleus. I don't want to write that one out. Then you have the dorsal paragigantocellular nucleus and the lateral dorsal tegmental nucleus. That one's a little easier, the LDT. We'll say pedunculopontine tegmental nucleus, and then dorsal paragigantocellular nucleus is DPGI. Anyway, so you've got these two guys right here are cholinergic. They actually go that direction, right? But I'm just going to draw it this way for the sake of understanding. So they're cholinergic, and they are going to help inhibit some of these wakefulness centers and help transition into REM sleep. So they block some of the activity of these other guys that inhibit the sub-C, so they allow the sub-C to be activated, and then that'll help you drift into a deeper sleep. So these are things that can help you kind of shut the mind off. People that can't turn their mind off before they fall asleep, that's important. The VOPAG has two kinds of neurons there. So it's got an inhibiting REM, so it's REM active, REM inhibiting, okay, so the REM inhibiting is ultimately going to inhibit the sub-C, so you can't get there. So that's going to be like, hey, wake up now. So that's why it's a problem with the REM sleep behavior disorder, because they don't wake up. Like they can bash their face into something or kick something, and they're not falling asleep, they're staying awake. Or they're staying asleep and not waking up, regardless of pain or anything like that. And then on the other side, REM active is going to block two things, the locus coeruleus and the dorsal raphe nucleus. And this is also kind of where this, along with the lateral dorsal tegmental nucleus, that also has a little tangent. The LDT will project up to the nucleus accumbens. We'll just have a little stem over here to the NAC. And that has a big role with like ADHD stuff and a lot of the mental health things, because we have these problems. Dorsal raphe is your main like serotonin area, and this is your epinephrine center, right? Or yeah, so they're involved in a lot of things. So we know when we treat these things, there's a pretty solid result already, but if it's getting into their sleep habits as well as other things, you can be looking at some of this stuff. I don't necessarily have all that yet, but it's coming. So yeah, back to this. Those inhibit those areas because they keep you awake. And then if they're keeping you awake, that's when you get the mental health problems. But that's their function there. And then this is getting its information up from up this way as well. So that's how those guys work together. Yeah, so lateral dorsal tegmental nucleus also regulates the ventral tegmental area, which is another dopamine center, right? So it hits the basal ganglia and that, so that's rather important. DPGI right here, that'll inhibit the VOPAG, locus coeruleus, and the dorsal raphe, so it hits all of them. Again, more for this particular portion, not this part. The VLPO and the hypothalamus, this guy, is going to come and inhibit this side, the REM inhibiting neurons of the VLPAG, so that this can then be active, which then allows that to be active to get that to happen. So this pathway is also going to involve that. So there's the general breakdown of sleep to how we understand it at the moment and what you can do about it.